from the Seattle Science Foundation and Swedish Neurosciences Institute. My name is Matthias Costa. I'm one of the Cerebrovascular Fellows here, and I want to thank Swedish and SSF for providing us a platform to do these talks. We produce these talks along with the attendings, the fellows. Dr. Cameron McDougall, the head of our department, is also joining us today, as usual. We are blessed to have Dr. Iype Cherian with us this morning. He's a neurosurgeon from India who was the lead of the department at Cisternal Neurosciences Institute in Nepal for many years, where he did tremendous amounts of work in neurosurgery and helped that beautiful population in need for many years, offered them high-end cerebrovascular and skull-based surgery, which they didn't have before. During his time there, he developed, among other concepts, the cisternostomy in trauma and different tools such as the hyperscope, the water knife, etc. Nowadays, he's back in India, continuing his tremendous work to advance the field of neurosurgery. And we have the privilege to have him speaking about these topics, especially cisternostomy, the lymphatic system, and some basics for all of us that really don't find these topics in our daily practice. So thanks, Dr. Cherian, for being with us, and welcome. You can share your screen.
Thank you, Matthias.
Thank you.
It's an honor. I'm trying to share my screen right now. 1 second. Okay. Yes, you can see my screen.
Yeah, you need to put it. Yeah, that's fine. Thank you.
There we go.
I almost read your thoughts. Huh? Now, that's what I would try to start with. Mind is the biggest lab. In fact, if we have a very equipped lab and if we have a poor mind, we're not doing much work. On the other hand, we realized that in a country like Nepal, we didn't have any lab. So we started to develop, we started to think. So I'm going to tell you some random thoughts of mine, which, this is Nepal. I was there for 14 years. We developed centers from west to east, started in the west, then in the middle of Nepal, and then went to the east. So for 30 million population, we developed 3 neurosurgical centers south of Kathmandu. That I consider as one of my greatest achievements, where maybe much more than cisternostomy or any other things. You can hear me clearly?
Yes. Yeah.
Okay. Now, I'm going to tell you a few random facts. The brain takes 1/5 of the blood supply. It's a chemical energy, literally. It's a metabolic energy. It's not electrical energy as such. So it takes 1/5 of the blood supply, and you have a lot of chemical byproducts after it goes through these energy cycles. So how is it cooled? How is it cleaned? And without cleaning and cooling, can it function? And we always thought the CSF was just for flotation. Is that the function of CSF? If so, why is the CSF changed 3 to 4 times in a day? And lastly, we talk about air sinuses. We have these air sinuses. If you ask people, they say it's to humidify the air. They say it's to amplify your voice. People say it's like a crash zone for the collapse zone for accidents. Do you think this is the reason why they were made? So these are some random thoughts. We're going to answer them in my presentation. And this all came through because after our cisternostomy discovery, we had to find out the answers for a lot of questions. And these are interesting things which you will see now. In 2007, we started thinking about these questions. And I had this crazy thought that the sinuses are actually meant to cool the brain. When I told that to my friend, Margarita Beltran, who was a neuroradiologist, she told me this is crazy. But we looked at the literature and we found that Around the sinuses, the temperature is around 4 degrees down. You know how it happens is also very interesting. Now you know that the sinuses, when we breathe in, the air goes through all these sinuses, and the sinuses are lined by wet mucosa which evaporates. So this is exactly that is happening. So what is happening? The sinuses are here. The sinuses are here, and the largest cistern in the brain, suprasellar cistern, is right in the middle of the sinuses. It's crazy, but you know, if you look at it, it's crazy. But anatomically, it's right in the middle of the sinuses. And you see, when you have warm air, then you have wet mucosa, and this water evaporates, and then you have cold air. So this is the same principle. So what happens is the suprasellar cistern, by convection, because the sinuses start evaporating, and then because the suprasellar cistern is right in the middle, the suprasellar cistern is cooled. Now, after the suprasellar cistern is cooled, how does that cool CSF go into the brain? That's another thing we started looking at. So this was an answer. You know, you see this. This is how the Ganges reaches the Bay of Bengal. This is how the Ganges reaches the Bay of Bengal. If I start talking about this pattern, it's based on Fibonacci's equation and the golden ratio. Okay, so we will skip that. But you see this pattern. This pattern is very common. This pattern is for arterial pattern, trees, sunflower holes, clouds. Every anatomical pattern follows this. This is a satellite picture of the Ganges reaching the Bay of Bengal. Now you look at it. Now you take this is the cistern, and this is how the vessels go into the brain. And around each vessel, there is a space, there is a CSF space, through which the CSF in the cistern can communicate into the brain. Deep to the up till deep. Imagine this is like a literally like a vascular cast. So the CSF can reach to every single corner of the brain. Okay. Now, how does it reach? That is when I was teaching in the masters in France, WFNS France, for the WFNS anatomy. We went to Leonardo da Vinci's museum, and I saw, this is another picture which shows this cast, and this is what I saw. You know, anybody can identify what this is? This is called an Archimedes pump. Yes, well, Cameroon. Yeah, so that's an Archimedes pump. You know, the CSF reaches from the cisterns to all the corners of the brain using an Archimedes pump principle. Only thing is, it's a bit different. This is how it reaches. So this Verschuroven spaces contains these pulsating vessels. So these vessels have these pulsations. So you can actually see them in vivo. There are some beautiful in vivo images my Chinese friend has developed. I mean, he's got these videos of these beautiful vessels, small vessels pulsating. And when it pulsates in the Verschuroven spaces, you're literally creating an Archimedes pump. You're creating a wave through. So the CSF is going in. So we found out that how the CSF is cooled, and then now we know that the CSF is actually, the cool CSF from the suprasellar cistern is literally pumped into the brain using this Archimedes pump principle. You see, these were crazy thoughts we had at that time. Now there's a lot of evidence for this. Okay, we didn't have basic science labs, but then Nedegard and the rest of their groups, they have independently published and they have proven our hypothesis at that time. But you see, this is all our thoughts and our line diagrams. Now, this is from one of Nedegard's contemporaries' articles. This is the cleaning pathway. It's the same thing. So you have the perivascular space, and cleaning only happens in the night. That's why we must sleep. And for cleaning to happen, the neural activity must be bare minimum. So when you're sleeping, the aquaporin 4 channels open up in the night. And then the CSF in the perivascular spaces are pushed into the ISF. They take all the metabolites and then they go via the perivenous space. And this is this beautiful glymphatic system. So if you are not sleeping, that's why you're not very fresh next day. So they say fresh as a daisy. You will be not very fresh. So if you are not sleeping, and I believe sometimes that yawning is a final attempt to cool the brain. You know, when you do for that, actually the sinuses are getting cooled a bit more, and then that's a final attempt to cool. This is what I think. I don't know. These are crazy thoughts, you know. We published that in the Springer's textbook, though. So, is there any evidence? Yes. So, the ventricular, this is the ventricular infusion of markers, and this is a cisternal infusion of markers. You can see the clear difference. This is why an EVD doesn't work, because the EVD plays on the compliance. An EVD doesn't literally drain the parenchyma, but a cisternal drain literally drains the parenchyma, because the CSF in the cistern and in the brain, they are communicating freely through the Varshavin spaces. So this is why we understood that cisternostomy can work while ventricular drain will not. A lot of people ask me this question. They ask me, why can't you put a ventricular drain? Why do you have to do all that skull base and go into the base of the brain? This is exactly why. So you can see the intracisternal injection there. Now we come to one of the practical aspects here. Now you have the cisterns here and all the vessels there. And now when there is traumatic subarachnoid hemorrhage, even aneurysmal subarachnoid hemorrhage, I'll tell you the difference between the two. In aneurysmal subarachnoid hemorrhage, it's a vessel bleeding. So the CPP becomes 0 in few seconds because the vessel just ruptures and bleeds. So the whole subarachnoid system becomes full with blood, and MAP becomes equals to ICP. So the CPP becomes 0 and the patient just falls. I mean, the patient just is like a thunderclap. I mean, the patient has a headache and he falls. So it is very different from a traumatic subarachnoid hemorrhage, where the bleeders are mostly arterioles and capillaries. So they keep bleeding for some time. And once the cisterns are filled with this newcomer's blood, once the cisterns are filled with this blood, the pressures in the cisterns are going to rise. From the normal pressures, the cisternal pressures are going to rise tremendously, almost 5 times more. And the blood cannot go in through these Varshavin spaces. So what is going through these Varshavin spaces? All the CSF is driven in. You have 120 ml of CSF in the cisterns. They are driven into the Varshavin spaces. And when that happens, it's like you take a 1.5 liter Coke bottle and try and inject 100 ml into, try and inject 100 ml. We literally tried this. We tried to inject 100 ml. It's impossible. The kind of pressure that Coke bottle goes through, is when you take out the syringe, the Coke will just, you know, it will just come like a fountain. It's exactly what was happening when people were putting small burr holes for acute subdurals. You know, the brain used to just pour out. So the pressure inside the intraparenchymal pressure goes up tremendously high. And when you're doing a decompressive, you're literally not addressing the problem. This 120 ml which came out is what comes out. The 120 ml went in, and you're creating a large 120 ml, 120 ml defect, and the brain is coming out, it's herniating out. So that is not the answer. So we started looking at whether we can actually open the systems, let out the blood, and create a backflow I mean, physiologically, whatever went in, can it come back? This is what we were looking at. So for example, so you have subarachnoid pressure, subarachnoid bleed, and then the pressures in the cisterns go up, and all the cisterns, you can see that in a severe traumatic brain injury, you cannot see any cisterns. That's because they're obliterated, not because the brain presses them. It's wrong, because no brain can press 100 ml of cisterns. No brain can press. If we only, I wish some of our neurosurgeons knew some hydraulics, because you know that, I mean, in science, it's impossible to press 100 ml. We try and take a 100 ml balloon and try to press it. It's impossible. Cisterns are absent because the cistern and CS are displaced into the brain. And that's where the pressure, the ICP rises up from. So what we have to do is we have to get into the cisterns. How much of a difficult it is if you get into the cistern and drain the blood. When the blood is drained and the cisternal pressure goes back to the atmospheric pressure, this backshift occurs. We can show you so many videos where once you open the cisterns, the blood pressure the ICP starts coming down and down. Then these are really, really angry brains. We can show you all day long, because we got over 1,500 recorded cystonostomies. So we can show you now. All my consultants and my residents and my fellows are doing it. So we have so many countries which have now published their results in cystonostomies. But DZ is this: when you have all that cistern and CSF has displaced into this brain, the brain is very tense, and you're going to open up a window, allowing the brain and all the fibers to herniate out. This results in so much of volume loss later. It's literally a crippling surgery. Of course, it's an old surgery. It doesn't use any microsurgery, but the principle wise, it's wrong. So now we're looking forward to Dr. Laligam Shegar's fellow, Shabarish, doing the trials. I mean, after the first randomized control trial has been published from India, so, and one more from China is out. The European study has been done from Lausanne. So now they're starting the trial from Laligam Shegar's fellows center. Dr. Shabarish Natrajan is starting that trial. So CSF shift edema, this was the evidence. So this was done from Calgary. And Dr. Garnet Sutherland was, he was a big critic of ours, and we were good friends, but he was a big critic. So then we came down to Nepal in 2011. That's almost 10 years back. And then he told me I wanted to see this procedure. And after he saw 5 of them, he said, I'm a convert. So he went back and he designed this experiment to prove CSF shift edema, and they published. Very interesting. So there's a weight. I mean, they told me I could prove it with a canine model, but I love dogs and I've grown up with dogs. I said I'd rather keep it unproved, so that I wouldn't want to sacrifice a dog for this, for making somebody believe this. So I didn't go ahead, but I think with the mouse, I did not have any problem Garnet doing it. So they found that the CSF shift edema, just like we proposed, the subarachnoid cisterns were full of blood and the brain was swollen with fluid. So this was the MRI findings, and then they had the in vivo, they sacrificed the mouse and they looked at the brain also. And these are the cystonostomy indication scores, quite different from decompressive, because this is a proactive surgery. We don't really wait for the physician to manage and then cook, and then finally have a cooked product in your hand and then try doing something different. This is not what we're doing. So we go ahead, it's a proactive surgery. So if you have some radiological and clinical features, you go ahead and do this surgery. The contraindications are this. There are some complications, but this is in the initial part of your learning curve. So most of my consultants and my fellows, we see these kind of complications with them, but once they pass the learning curve, they don't even think about decompressive. So I always ask them, is all this physiology as well as this microsurgery, isn't it time to discard a 100-year-old unrefined surgery for the most common problem in world neurosurgery? The most common problem in world neurosurgery is not aneurysms. It's not tumors. You put everything together, still trauma will be much more. So because 5/6 of the world is low and middle income countries, and the biggest neurosurgical burden for these countries is trauma. And yet we sticking on with a 100-year-old surgery. So we're trying to change that for the last 15 years. And I hope it's now we are on the runway, we literally taking off. Now, about the cooling mechanism, I told you. Now, the cleaning mechanism, we believe that most of the degenerative brain disorders like Brown's disease, Alzheimer's, Parkinson's, all these diseases may have a one common factor related to the disorder in cooling and cleaning of the brain. So we believe that. We have published that as well, but we don't have any evidence as such. And I'm sure this will open up huge avenues in research for in the future for these diseases. So my message would be breathe well, sleep well, and think about this in future research for this part. These are our publications. So we have this chapter in the Springer's Neuroscience series. This is where we publish, this is a textbook chapter. So we have some of, well, I also do a lot of skull base. So we have some of these chapters as well. This is now the neurotrauma chapters, the CSF shift edema, this is the publication. And well, cystonostomy, how it helps. This is the CSF shift edema that we published again. This is the orbitomeningeal band to do a bedless transcavernous dissection. So this is also important for type 3 cystonostomy. So this is our simple approach to extradural carotid. You should see that it's the most simple approach to classifying carotid segments. So this is a ipsilateral cerebellopontine angle cistern widening. So that is a very, very important radiological finding in patients with traumatic brain injury that indicates that your brain is herniating. And this is the anatomy and physiology done with Giovanni from Italy and Antonio from Weill Cornell. And these are some of our earlier classifications. We were listed in the GENOS. Cystonostomy is already listed in the GENOS as an option, and I was honored to be one of the people in the advisory panel. GENOS has come out. We couldn't do it as a randomized controlled trial, but now there's a lot of guys doing randomized controlled trials. At least 3 of them are going on, and 1 is already published. Large study has been just published. And this is the Hadri. This is just 1 hour away from my home. In fact, my future home is coming up just about a couple of kilometers from the park, which is about 1 hour from the hospital. In 15 years, I hope I can settle down here amongst these rather than in the city or town. I think I'm done. If you got any questions, I can answer. And if you want any videos of cystonostomy, this is one thing I wanted to show you, maybe under the high magnification, so you can see that. This is just exactly how I do my cystonostomies. So this is a type 3, it's quite tense brain. So we are reducing all the bone, everything. All the bone in the sphenoid ridge, everything, we are reducing it off. And once we do that under high magnification, that is a brain. So you can take out 35 ml of bone, which is huge. So a very, very tense brain, the moment you reduce all this bone, that brain is going to be less tense. And that is something that, the guys who are doing decompressive, that at least if they can reduce this much amount of bone jetting into the brain, you can actually do a lot of good. So you can go ahead and take sutures and then take off. I don't take the anterior clinoid off like this for my aneurysms, but after I've done the sagittal and the axial unlocking, this is rather, and confirm that there is no middle clinoid. For a trauma, I can take off the anterior clinoid like this. So very fast using a needle holder. And this is how we, and then this is how we open the dura. This brain was so tense that the temporal lobe had herniated, not only just over the third nerve, it had herniated over the carotid. So once we've done that, that's an injury. And then we go ahead and into the opticocarotid system, open the opticocarotid system. Take only 5 minutes. I mean, people ask me how much time do you take? It takes 5 minutes hardly. It's not an aneurysm, so you don't have to, you don't have to pussyfoot around. You just straight off go into the basilar. So that's the basilar, and you can see the superior cerebellar, PCOM there, the superior cerebellar on that side, and the contralateral third nerve also you will see now. So it's just like going for any posterior circulation aneurysm. Then once you, I mean, that's a superior cerebellar there. It's a superior cerebellar there. And above that, you will have since I've not dissected any sylvian, you will not be able to see this side, and you will not be able to see the basilar top clearly. And the urangle is not that. So you can, so that's the superior cerebellar there. That's the basilar there. Third nerve, the third nerve will be coming here. So you open up all that membrane of Rilliquist, and then you put in your drain. So that's your drain. I used to use a feeding tube. So this is a rather old video. So now we're using an EVD actually. But for almost 1,500 cases, we used a feeding tube number 8, so which is very cheap actually. But now we use an EVD. So you can see the brain now. We use our hand as see that is how we figure out brain is lax or not. We let our fellows feel the brain just before and after that the brain is so lax, and that's the difference. So that is one practical aspect we see. I'll stop sharing now. Thank you very much.
Thank you very much, Dr. Cherian. It was fantastic. So we have many questions actually. So
yes.
What is your protocol now for brain trauma? You do just cisternostomy and put the bone back?
Yeah, so for most severe head injuries, if the cisterns are obliterated, if the CPI cistern is widened, and there's evidence cisterns are obliterated, that means the ICP is over 25. There are papers on this. And if there's ipsilateral CPI, one side CPI cistern is widened, that means there is imminent herniation. So we go ahead and if there is a subdural, we take out the subdural and do the cisternostomy. And we always put the bone flap back. We don't do decompressives anymore. If there is the GCS motor score is 2 or 1, and if there is severe infarction, if there is features of infarction, that's the only time we do decompressive. But even if we do a decompressive, we keep a drain. We do a cisternostomy. We keep the drain for over 5 days and drain almost 180 to 220 ml every day. So we drain it every day, and so that will even the patients, 2 or 3% of patients who has to undergo decompressive also does much better than the usual decompressives. They don't have this brain leaking out, and earlier we used to see all that, but with cisternostomies, no more brain leaking out, nothing. The motor score was above 4. The motor score is it's a very important thing. So the motor score, if it's M5, the patients are going to be extubated less than 48 hours. Motor score is M4, M3. They're going to be extubated maybe in a week. If they're not extubated in a week, then we do a tracheostomy and they're going to come back quite okay. So, and the most important thing over the last 15 years we've seen is there's no brain volume loss. This is the most important thing. When you do a decompressive and when you're going to do a cranioplasty, literally you have nothing there. It's just, I mean, the brain is like the flap is like sinking down. But you know, when you do scans we can show you scans of cystinostomy when they come follow up. There's minimal wasting, but it's nothing at all like decompressive where you lose entire brain volume and the patient's functionality is very much reduced.
Okay, that's nice. And you leave a drain just in the cisterns, right? You don't use EVDs anymore.
Beg your pardon?
You don't put EVDs anymore.
No, we do. It's very important to put an EVD. Actually, we used to put a feeding tube before, a number 8 feeding tube before, but now we use an EVD.
No, but I mean into the ventricle. You don't use a ventricle.
Oh, no. We don't put a ventricle. We don't put it. The Chinese Wang's group, they put an EVD as well as a cisternal drain. They use the EVD for ICP measurements, but we don't do that. We put just a cisternal drain.
Can you measure ICP with that cisternal drain? It's not reliable.
So it's a trend. So when Wang puts both ventricular drain and cisternal drain, he finds that the ventricular drain is on an average five more than the cisternal drain, 5 millimeter Hg more than the cisternal drain. So maybe it is just probably a trend. We can measure it.
Okay, so there is a question here. What is the minimal equipment to perform this surgery?
Microscope.
Okay.
You cannot do it without, a lot of people ask me whether they can do it with a loop and all. No, I don't advise doing it with a loop. You need at least a very basic microscope, but with the microscope you can do it. Without a microscope, no, it is difficult.
Are you able to reach the cisterns like in every case? Because you know sometimes the brain is extremely tense and you can't just work.
I can show you a few cases where the brain is leaking out. Okay, let me just see. In every case you can reach, except when there is infarction. So if there is an infarction, it is like really difficult. So that's the only time I cannot reach. But otherwise, almost every time that you can reach, you can reach. Okay. I cannot see this on. I cannot see this on my offhand, but I can show you sometime. If anybody who's interested, they can mail me and I can show you videos where I can show them brain leaking out, and then we are able to get into the systems. And after they are open, the brain is manageable and lax.
Okay, and which groups in Asia and Europe? I mean, are people doing cysternostomies routinely in some other places?
Yes. In Europe, CHUV Lausanne is the pioneer. So they started about 7 years back. They have a lot of patients right now. They published in ACTA, and they have very good Roy Thomas Daniel and Lorenzo Giamatti, their group has published a lot of articles on cysternostomy in ACTA and World Neurosurgery. And also in Jiří Fiedler's group in Czechoslovakia. They are Czech Republic. No, there's no Czechoslovakia right now. I remember. So in Czech Republic, Jiří Fiedler and his group, they are doing it. There are many in Belfast. Dr. Iype had started it in 2011. And then many other places had a problem because cysternostomy is not an accepted surgery. So we had told them, see, we're not doing anything different. We are doing a large bone flap. And after that, we are evacuating the subdural. And opening cisterns is something that has existed for a long time. So if you see, people used to cut the tent, they used to do onchocerctomy. They used to do different things like onchocerctomy, cutting the tent to reach the cistern. There are more than 60 papers. So that is also nothing new. And there is a clause in decompressive hemicraniectomy that if the brain is lax, you can put the bone flap as a floating flap. So there's nothing new that we are doing. You see. So we told them that you don't have to name it as cystonostomy. And so a lot of guys are doing it right now. In Asia, so many are doing it. I mean, in China, there are at least 3 large groups doing it. They have their trials and everything done. So I frequently go to China and well, Iraq, Iran, India, so many guys. Dr. Parthiban is one of the biggest proponents in India. Nepal, I was doing it right now that I've come back. So we have fellows from almost all parts of the world, especially from South America. Now Manuel Encarnacion, who was with us. So he is also, I think he's writing something. So he was with us. He saw Cisternal. He started it in Russia. He's from Dominicana. So many places we have. We have a Cisternal group with more than 100 people. So these guys are pretty good doing it.
So another question is, what kind of edema creates the CSF shift? Is it hydrostatic, right?
No, it's completely very different from hydrostatic. So CSF shift edema is the movement of CSF from the cisterns into the Verschurovin spaces. It doesn't go into the ISF. So it is staying in the Verschurovin spaces. But the problem is when it stays in the Verschurovin spaces, the intraparenchymal pressure is going to go up tremendously. And that produces decrease in CPP. If you have a hypotension, then you're finished off. So if this fluid is displacing into the intraparenchymal region, this is why some people, when they do earlier they used to do small burr holes for acute subdurals, and the brain just spouts out because the intraparenchymal pressure is so high. And you've seen in decompressive sometimes that when you take off the bone flap, the brain just comes out. But if you go into the cisterns, the next time you see that, all of you who are listening, if you see that kind of a swelling, go down. There's so many reports of that. Unmanageable brain swelling managed with cystonostomy, and so much. There are so many papers on that, case reports on that. So see that, go into the base of the brain. You may have to retract a bit more, but a little bit of frontal lobe is a small price to pay rather than having a dead patient or a comatose patient. So Pablo Villanueva, who's writing it, he's in Matthias Baldoncini's lab in Argentina, Buenos Aires, and he is performing a dissection for cystonostomy about the cisternal definitions and how to open them and all that. So I've seen the initial paper, it looks very promising, and this is something that will be a very important publication for us.
Yeah. So one question that is, I mean, one of the main critiques is why cysternostomies and not put an EVD? I know that you explained that, but can you go deeper in that?
Yes. So I will go back to this slide. This is a simple slide that you have to see. You see this, the ventricle is not directly connected to the parenchyma. So if you inject any markers into the ventricle, they don't come into the parenchyma fast. So they are not, the ventricle is just a protection phase. It is not connected. So, but the cisterns, they are connected to the parenchyma, like they are part of the parenchyma, which means they are communicating with the parenchyma so easily. So when you put in a ventricular drain, what you're doing is you're playing with the compliance. Because the ICP is so high, you take out 2 ml of CSF from the ventricle, the compliance, you're just playing with the compliance. But on the other hand, when you're draining the cistern, you're literally draining the parenchyma because they're connected. They're very well connected. So this is the answer. If you put an EVD, we've all done this, but I mean, the ventricles are collapsed and you're putting in an EVD, and then after that, you get about 2 ml or 3 ml in an hour. And after that, most of the time it gets blocked off. That is not the answer. You cannot decrease the ICP to such an extent like you can decrease the ICP in opening the cisterns. So there are pictures where Jerry Fittler has shown that after opening the cisterns, the ICP has gone down from 28 to 6. He's got this dramatic picture of the ICP trace. So I wish I could have shown you that picture as well. So, but many of my earlier presentations has this picture. So this is the answer. So putting in an EVD is not, you're not physiologically addressing the problem.
Okay, my partner here has a question.
Thank you, Dr. Cherian, for your presentation. One question I have is, what about the idea of putting the catheter in through the lamina terminalis? And then that way you get the advantages of ventricular drainage and cisternal drainage using your technique.
Right. So excellent question. See, we used to open the lamina terminalis. You know, Yuha, who's a very good friend, he used to work with me after his retirement. He was with me in Nepal for about a year in my center. So he had asked us, let's go open this lamina terminalis. We opened the lamina terminalis, but then when there was no ventricular blood, we found that we were introducing ventricular blood. So the incidence of hydrocephalus was very high. So when there's no ventricular blood, there's no need for opening the lamina terminalis. Although it may appear to be, when you open it, you have a gush of CSF and you can put in the catheter. I mean, your idea of putting the catheter in is fantastic. But we don't open the lamina terminalis these days because if there's no ventricular blood as such, you could just as well, the lamina, do you know the difference between the cistern and the lamina terminalis? It's about 0.1 millimeter membrane. I understand that this can withstand a lot of pressure and can have pressure differences, but it's just a very, very thin membrane. So you're just going in and you're putting in a ventricular drainage. But if you put in the drain between in the pre-pontine system where the pons is relatively a firm structure and you have clivus, you're going to be draining almost 180 to 200 ml every day. My fellow Tamerlan is sitting here with me, and he will tell you that every day you drain about 180 to, you have to change the bag every day in a ventricular drain, and it doesn't get blocked. Okay. Only time it gets blocked is when you have a patient developing an infarction or something. That's the only time it gets blocked. Otherwise, never. It continuously drains this 180 to 200 ml.
Okay. Do you think there is any relationship between this CSF shift theory and for example, normal pressure hydrocephalus or some other entities of the kind?
You mean the CSF edema?
Yeah, like there's some kind of hydrocephalus you of course know, like low pressure hydrocephalus, in which you put any kind of drainage into the ventricle and you see that the pressure is never high, and somehow the patient improves anyway.
There was a time for tuberculous meningitis and hydrocephalus, we used to open the lamina terminalis. We used to call it the anterior third and it didn't work very well. It would work for some time, and then after that, it will get closed all over again. So I really don't know whether this works. And somebody's asked the question about strokes. I want to answer that also. There is this group, Italian group, Massimo Cardali's group, who are doing cysternostomies immediately after the window period is over, so over for all the other interventions, but way before the malignant brain edema develops. So they're doing it. They're doing it in Italy, and their group is doing the cysternostomy. It was inside the cysternostomy WhatsApp group. So, and they are finding excellent results. So in a group in US, Sabari's group is also doing this for strokes. Much more proactive than decompressive. So to convince your ICU guys to get it done is very difficult. But then when you see the pattern, you know that this guy is going to go for a malignant brain edema. So those guys, they benefit a lot, and they end up not needing decompressives at all. So this is the only time I have no experience at all doing cysternostomy for decompressives, because cysternostomy for ischemic stroke, because the time they come to us, the brain is literally, these guys are literally pupils dilated, they're gone. So if you get it early, maybe this is a very good time to go and do a cysternal.
Okay. So how do you apply all your concepts to aneurysmatic bleedings? For example, you have a MCA bifurcation, bleeding, aneurysm. You only open there and clip, you go all the way down to the cisterns and open everything up?
Depends on what's the grade of the bleed. You see, in India, in Nepal, I must have operated more than 800 to 1,000 aneurysms, and I can clearly count in my fingers how many unruptured aneurysms I've got. I don't get any unruptures. So it's not, if it's an unruptured aneurysm, or if it's a fissures grade 1 or grade 2, I can go localized and then clip. But most of these aneurysms that I see are mostly grade 4 and grade 5. And so the brain is really tense. So I always open the cisterns, wash out the entire blood, and I wait for the brain to get lax before I go in and I go and clip the aneurysm. So it's a completely different scenario from what you see, where you're seeing a lot of unruptured aneurysms.
Okay. Dr. Cherian, last question. What are the main critiques that you have faced in your journey with cystonostomy?
It's crazy, but I really don't remember, because I forget all the bad memories. I have had fights. Initially, I've been laughed at. I remember in 2007 going to Cambridge and presenting my series of 9 to 10 cystonostomies. In Nepal, I didn't have a microscope camera. So one of my fellows used to record with the TRV 786, that Sony video camera. He used to record what is inside. All we could see was that the tense brain, and it was getting lax. We showed that, and then we told the Cambridge group that Monroe Kelly doctrine was wrong. So I remember those guys telling me it's interesting. Then I found out with my English friend that when the English says it's interesting, that means the English means that it's nonsense. So we started off there. We were the entertainers at first. Then we started putting doubts into everybody's minds. By 2010, 2011, we started putting doubts into everybody's mind. We could see that people were confused. And then the older generation, they were like, we're not going to change. We're never going to change. Whatever you say, how much ever proof you bring, we're not going to change. And they were dead against us. Even now, that's the generation which is dead against us. So I've told Randy that unless you guys die or retire, it's never going to, come into vogue. So that's how every change is. But then I could have done just skull base. And a lot of people told me that, why are you going to trauma conferences and fighting with these guys? Why should you just not stick to skull base and vascular? You're doing pretty well there. But then in my country and most of the countries of most of the world, biggest problem is trauma. And there are so many millions of patients who suffer because of this 100-year-old surgery. And so many of the residents has to go to United States and Europe to see microneurosurgery in a theater, and they have to stand there like that, while they have the chance to do excellent microneurosurgery if they practice cystonostomy. They don't have to go to any theaters. And the patient, it's a win-win situation, you see. But then because most of the policies on head injuries come from the West, it's like earlier days, the British used to teach us how to treat tuberculosis, where they had no tuberculosis, we had all the tuberculosis. So they were teaching us how to treat tuberculosis. It's the same thing right now. So head injuries are our problems, and it's primarily our problem. So we should be teaching it to the world rather than somebody who's got a trauma. Some guys come and talk about their number of trauma they do in a year. It's like what my resident does in a week. So this should not be the scenario. I mean, there are some things everybody could see. We don't have the infrastructure or anything, but we have experience. So we should be, teaching these kind of things. And I think microneurosurgery should come to trauma, not only because of all the physiology that I told. It's important. It's very important because the results are so drastically different. You guys should come here and see the difference.
Okay, there is one question from the chat here. If you have tried any kind of endoscopic technique for cisternostomy.
Imagine just cisternostomy alone, people are ready to, if we were 500 years back, they would have burned me at the stake. If I told endoscopic cisternostomy, in my mind, I had a lot of, in my mind, I had thought about it. Why don't go? So we started doing a supra-brow craniotomy and started doing cisternostomies. But then when the consultant started doing that, we had some disasters. So we said, no, we're standardizing this. In fact, I still do operate basilar aneurysms with a small suprabrow craniotomy. So if you have that experience, fine. But then you show this suprabrow craniotomy and cisternostomy. The next thing that you understand is a resident who is into his 4th year does a suprabrow and then goes into a tight brain, and he wouldn't know where his front is or back is after he's into the brain. So that is what happened. So we wanted to standardize things. We didn't want to go do any crazy things to start with in the 1st year. But I guess this is a fantastic idea because you're directly into the cisterns. But when you reach there, when you open the cisterns, you've got brain coming out through the nose, you're in trouble. So maybe you don't want that. So maybe, I don't know, maybe I'm too old to change right now, perhaps.
So certainly you changed a bit we will never think about trauma the same way because this concept is already in our mind now. But you're an example of persistence, even low resource countries, and we really appreciate that and respect that. Wow.
Third world is in your mind. Third world is always, first world and third world are in your mind. It's nothing to do with geography. It's just in your mind.
Yeah, I agree.
Thank you.
Thank you very much. It was fantastic.
I really enjoyed it. I love your attitude. I love your approach. You're just so beautifully presented. I really appreciate your time. Thanks so much.
Thank you, Cameron. Thank you so much.
Thanks, I.
Bye now.
Bye-bye.